Good afternoon, everyone. My name is Kathy Vincent, and I'm a former senior deputy with the Alabama Department of Public Health. I'm currently consulting with the Health Systems Transformation Team at the Association of State and Territorial Health Officials, or ASTHO as you know it. I would like to welcome you to today's Payment and Delivery Reform Technical Assistance Call, how state public health can invest in healthy communities to improve population health. As many of you know, ASTHO is committed to supporting state and territorial health officials and their leadership teams in reforming models for payment and delivery services within transforming health systems. With support from the CDC, we're working with states and territories to build capacity and strengthen their ability to integrate population health activities into overall health systems transformation plans. Today's call is the first in a series of 4 focusing on some of the key issues involved as you move forward. The objectives for today's call are to increase awareness of the Federal Reserve Bank's Healthy Communities Initiative, to highlight case studies which identify opportunities for state public health to address health disparities within the Healthy Communities framework, and to provide insight around how business and health sectors can partner to improve health outcomes of a community. Now I'd like to introduce today's speakers. Elizabeth Sobel Blum is the Senior Community Development Advisor at the Federal Reserve Bank of Dallas. David Erickson is the Center for Community Development Investments Manager at the Federal Reserve Bank of San Francisco. If you have a question during the call, please post it in the chat box on the left of your screen at any time. These will be answered during our Q&A session at the end of the presentation. We'll also open the phone lines then for you to ask additional questions. At the end of the call, you'll be directed to an evaluation survey. We ask your help in taking a few minutes to complete the survey so that we can use your feedback to inform our future work. I'll now turn it over to Elizabeth and David. Elizabeth, I believe you're first.
Thank you very much. My name is Elizabeth Sobel Blum, and I'm with the Federal Reserve Bank of Dallas. So the Federal Reserve is a central bank of the United States, and we provide the nation with a safe, flexible, and stable monetary and financial system. David and I are from the Community Development Function of the Fed, and our role is to promote community and economic development and fair and impartial access to credit. Our activities include conducting research, writing publications, facilitating partnerships, designing and hosting events, and public speaking. I'd like to go over right now just go over my brief disclaimer that the views expressed by us those are our own and not necessarily those of the Federal Reserve banks or the Federal Reserve system. Okay, so health is an asset. Why does the Fed care about health? Because the health of our nation, our people, affects the health of our economy, and vice versa. The health of our economy affects the health of our nation. Specifically, there is an inextricable link between health, education, and income. In general, the more education you have, the more income you'll earn over your lifetime, and higher education can translate into better health. According to the Robert Wood Johnson Foundation's Commission to Build a Healthier America, 25-year-old college graduates, on average, live 8 to 9 years longer than people who have not completed high school. They also, on average, live 2 to 4 years longer than their counterparts who have not completed college. Excuse me, let me clarify that 1 second. The contrast is not just between the two extremes of people who have a higher education versus those who don't. People who are 25 years old, on average, who have graduated from college, can expect to live 2 to 4 years longer than their counterparts who have attended but not completed college. I hope I clarified that. So what should we do to protect, support, and promote health? Where should we direct our focus to protect, support, and promote this asset? As public health entities, you are probably very familiar with this chart. It's from the County Health Rankings website, and its message is clear. Our health is mostly determined by our behavior and environment. And the social determinants of health are of common interest to not only the health sector, but also the community and economic development industries. According to the Robert Wood Johnson Foundation and University of Wisconsin Population Health Institute, 40% of our health status is determined by our education, employment, income, family, and social support and safety, and community safety. 30% of our health status is determined by our health behaviors, such as our tobacco use, diet and exercise, alcohol and drug use, and sexual activity. And 10% of our health status is determined by our air and water quality, housing, and transit. That means that only 20% of our health status is determined by our clinical care in terms of access to care and quality of care. While this statistic may be surprisingly low, it doesn't trivialize the importance of medical care. Clearly, living in a healthy neighborhood is no consolation if you're sick and your illness could bankrupt your family, financially, physically, and/or mentally. What is crucially important to recognize is the extent to which zip codes matter. Our zip code tends to be a more accurate predictor of how long we live than our genetic code. As shown in this map of New Orleans, babies born in a neighborhood not far from the French Quarter can be expected to live, on average, until the age of 55, while babies born a few miles northwest in the suburban Lakeview neighborhood can be expected to live up to a generation longer, until the age of 80. This pattern is not unique to New Orleans. It's a pattern seen in communities across the country, and it is preventable. Several years ago, bankers were asking me, what is healthy communities? We keep on hearing this, but what does it mean, and how is this relevant to our work in community development? In response, I wrote a publication that answers this question. As a whole, it shows that healthy communities is community and economic development. It's difficult to overstate this, so let me repeat it. Healthy communities is community and economic development. Included in this publication is a checklist of the components of healthy communities, as you see on the screen. All are integral to healthy, vibrant, and resilient communities. There is no perfect community that scores an A+ in terms of making sure that everybody has access to these components. However, this checklist serves as a starting point for communities to map where they're strong and where they need to invest to make healthy the easiest and most attractive choice. I'd like to point out that aesthetics includes a clean and well-maintained environment, landscaping, art, and culture. Building financial capacity includes financial literacy training, quality financial products and services that maintain and build assets. The built environment includes complete streets, housing, schools and workplaces, parks and playgrounds, pedestrian walkways and bike trails, brownfields, and open spaces. Early childhood development includes early childhood education and care. Employment includes creating and retaining jobs as well as job training. Personal and public safety includes addressing crime. Public transportation includes transit-oriented development. And social network, social environment includes democracy building and community engagement. There are a number of organizations working with communities that are struggling with their health, income, and education. The community and economic development industry works to support and promote healthy communities. It is in the zip code improvement business. Examples of its investments and activities include building housing that is affordable and safe to low-income households, financing charter schools, child care centers, community centers, grocery stores, health clinics, and other community facilities, providing training and small-dollar loans to entrepreneurs who are not yet creditworthy to access mainstream bank products and services, and helping people build and repair their credit and access quality financial products and services. For example, they could access small-dollar loans that are safe and don't get people in worse debt than when they got their loan originally. Community and economic developers partners include banks. In fact, banks are required to engage in community development. Why is this? In 1977, the Community Reinvestment Act, popularly known as CRA, was enacted to prevent redlining and encourage financial institutions to help meet the credit needs of all segments of their communities. Under the CRA, each bank is evaluated on how well it serves its assessment area. And its assessment area must include geographies in which the bank has its main office, branches, and deposit-taking ATMs, as well as surrounding geographies in which the bank has originated or purchased a substantial portion of its loans. Community development activities are loans, investments, and services, such as in affordable housing, community services that target low and moderate income individuals, economic development, and revitalizing or stabilizing low and moderate income geographies. If you'd like to learn about a bank's community development activities, I suggest that you call and ask for their CRA public file, Community Reinvestment Act public file. They're required to provide it to anybody who asks for it. This file should include information about the context in which the bank's performance should be evaluated. The healthcare system also has an important role to play in helping build a culture of health. Under the Affordable Care Act, also known as the ACA, nonprofit hospitals are required to do a community health needs assessment and then a community health improvement plan that says how they'll meet the identified needs. What is interesting to note is that the information in the CHNA overlaps with the information in bank's CRA public file. By reading these reports, you can learn about banks and nonprofit hospitals' works in healthy communities and identify potential opportunities to collaborate with them. Employers also have an important role to play in helping build a culture of health. And notice I'm saying employers here because it's not just for-profit businesses, it's not just the private sector, it's anybody who's an employer. And they care about health to protect their bottom line. Listed here are some of the health and wellness factors that hurt employers' bottom line. They include low morale, presenteeism, which means low productivity, absenteeism, employee retention and turnover, health plan premiums that keep on going up, workers' compensation, and disability. According to the Population Health Institute publication, as much as 50% of company profits go towards these costs. Some of the Public Health Accreditation Board's accreditation standards overlap with the standards, requirements, concerns, and interests of banks, nonprofit hospitals, and employers. These are some of them. You'll notice that 3 of them overlap exactly with what we just covered. If you look at Standard 1.3, analyze social and economic factors that affect the public's health, that's included in CHNA as well as the CRA reports. If you look at Standard 3.1, provide health promotion interventions to support prevention and wellness, that's very much in the space that the employers operate in to promote their employee and their family's health. In Standard 7.2, identify and implement strategies to improve access to healthcare services. That's very much aligned with nonprofit hospitals who are required to do the CHNA as well as a follow-up community health improvement plan. I genuinely believe that we can create a culture of health. We can make healthy the norm by making healthy the easiest and most attractive choice. We can do this by building upon the shared understanding that healthy communities is community and economic development. Let me repeat that. Healthy communities is community and economic development. Health and wellness are critical indicators of a community's strength, vitality, and resilience. So I'd like to conclude by sharing some recommendations for action. Number 1, prepare your story by putting it in a healthy community's perspective. Describe the complex link between education, income, and health. Explain why zip codes matter. Illustrate how your work supports or promotes healthy communities. And highlight the economic, financial, social, and environmental value of your work. Recommendation number 2. Reach out to organizations that focus on components of healthy communities that you'd like to learn more about. Learn their goals, successes, and challenges. Identify their community and economic development activities and geographic markets. Ask them about community collaborations that they'd recommend you join, and invite them to participate in your community collaborations. Consider bringing your top staff from government relations, market research, marketing, public relations, human resources, etc., so that they can share their expertise and learn others' perspectives. You can find a list of experts to reach out to in the appendix of the Healthy Communities publication from a couple years ago that I wrote. This is one example. CFED is a Healthy Communities expert. This is a sample of its programs and its policy agenda. And in the appendix, what I do is I list out 1 to 2 pages of what their programs, their products, their services are. In addition to that, I show which components of health on the Healthy Communities checklist they are focused on. So if you look at CFED, the 3 Healthy Communities components that are their areas of focus are building financial capacity, the built environment, and entrepreneurship. And included in this publication, which is online at the Dallas Fed's website at dallasfed.org, what you can do is upload the Excel version of this list of experts, and you can sort which of the experts listed are focused on the healthy communities components that are of most interest to you. Okay, recommendation number 3. As you decide how to address health and well-being issues, engage community entities and residents. Residents can tell you what will work, what won't, and what kind of change is valuable and meaningful to them. Without their input, you are not going to go very far. Number 4, use your expertise to promote a culture of health. Write an op-ed piece in the local newspaper. Share your research findings in public forums, for example, with the City Council. Or sit on boards of nonprofits that address one or more healthy communities components. Recommendation number 5. Ask your employer about their strategy to cultivate a culture of health. So this is about promoting health and wellness both inside and outside your 4 walls. Provide recommendations on improvement. For example, do they promote a family-friendly workplace culture? Do they consciously try to reduce stress in the workplace, such as by enabling employees to feel empowered to make important decisions? Is most of the food in the cafeteria, vending machines, and at meetings nutritious? Do they promote physical activity, such as by making their stairwells attractive and providing exercise classes on premises? And recommendation number 6, define success not only as learning what works, but learning what doesn't work. Reward partners for sharing these learnings and incorporate these learnings into the feedback loop. This process of continual improvement is vital to creating a culture of health. To learn more, here's a list of recommended readings, and David will go into a little bit of detail about these publications as well as highlight some case studies of collaborations in the healthy community space. And here's the link to the publication that I wrote on healthy communities, where you can find both the healthy communities checklist of components, of healthy communities components, as well as the appendix of experts. David, the floor is yours.
Thank you, Elizabeth. That was great. That was really helpful. And hi, my name is David Erickson. I'm at the Federal Reserve Bank of San Francisco. And what I like about the fact that you've got somebody from the San Francisco Fed and the Dallas Fed is you've got a good balance of sort of red and blue states, red and blue regions of the country sort of embracing this idea of how health can be combined with community and economic development, and how it's really been supported in all of these regions. And so I think this is just a really good sort of where the medium is the message here. This is, the fact that we're both on the call is an interesting observation. I'm going to, in my part of the presentation, I'm going to talk about some concrete examples of how these 2 worlds come together with their allied sectors to improve population health in neighborhoods. And I'll get to that in just 1 minute. But I'd just like to say, Elizabeth highlighted some of those books that we've done recently. The one I should just draw attention to your audience is the Investing in What Works for America's Communities. One of my favorite essays in there was written by Risa Lavizo-More, the head of the Robert Wood Johnson Foundation. And the last line of that essay, she says, "In the near future, we'll look back on this time and wonder why health and community development were ever separate industries." And it's a really powerful idea. And just a few weeks ago, she came to a conference that we held in Los Angeles to be the closing keynote speaker. And here was a room full of 1,300 bankers. And it was just a remarkable experience to have her stand before them and say, I would say, she asked, how many of you know, have you ever heard of the Robert Wood Johnson Foundation other than the tagline on NPR? And maybe 10% raised their hands. This is a group that doesn't know RWJ. She said to that audience, you here in this auditorium, you bankers are perhaps the most important healthcare workers of our time. And it's really a powerful idea that a doctor was saying that to a room full of bankers about how if you could find ways to finance ways to improve zip codes through health, you really can move the needle on health of the nation. So I just wanted to open with that. Let's skip ahead. We'll start with those. We'll go back to that slide with the Refresh Project. Elizabeth mentioned that, and we started talking a little about this healthy communities work. The Federal Reserve has been working with Robert Wood Johnson and hosting conferences around the country. We've had 24 of these conferences now so far since 2010. And they're really remarkable, and I hope you get a chance wherever you are in the country or in the territories. You are covered in some respect by a Federal Reserve regional bank, and so I would encourage you to reach out to them as a potential partner or at least a convener to bring health together with community development. These conferences tend to be very exciting. I mean, those of us who do community development and anti-poverty work, it just gets depressing after a while. You know, the job that we do is just sort of feels like you're rolling the ball, the stone up the hill, and sometimes you feel like you're not making much progress. But when you join forces and you're in a room of people who think like you think, even though they come at it from a significantly different sort of mindset, it's very invigorating and exciting. And I think the last one was in Montana at our branch in Helena. And the excitement was palpable. Where hospital systems and health insurers, they had recorded statements from the two senators from Montana. They had the lieutenant governor came to address the group. I mean, it really was exciting to see so many people coming around to this idea and thinking about how we can be better at cross-sector interventions that help improve population health. So I'm going to give you three concrete examples before we get into the Q&As. And the first one is really focusing on access, is using sort of food as the organizing principle, access to healthy food, and the second one is an example where a housing authority and a hospital combined, and that one has a fair amount of state financing in it. So I wanted to include that as an example of how they improved a low-income neighborhood. And then the last one is one in Atlanta, Georgia. And it's a pretty straightforward community development example that doesn't include health explicitly, but they are coming around to the idea of health. The reason I thought that was an important one is because it is part of a network of similar interventions that are now happening all across the country. It's the purpose-built communities, and they have almost 50 communities across the country that are sort of engaging in a similar model. So I thought that might be helpful in the sense that you might be able to you might have one of these near you. So those are the three examples. I'll jump into the first one. The first one's called the Refresh Project in New Orleans, and you're looking at this photograph. This was an abandoned supermarket that was on a street called Broad Street. It's on. If you remember, if you can think back to that slide, we won't go to it now. But if you can think back to the slide that Elizabeth showed, where there was life expectancy of 55 years near sort of the French Quarter in New Orleans. This is not far from there. This is just on the other side of the 10 freeway, just beyond the French Quarter. It is a community that has experienced severe disinvestment over the years. One of the crippling blows, even though in the early 1900s this Broad Street had quite an active commercial corridor, the interstate system, when it went through in the 1960s, really devastated the flow of customers, and the number of closed and shuttered buildings and stores fronts along this street are pretty significant. It's 25 blocks long. There still though were some real great resources in this neighborhood, even though it was struggling. So you had a few small businesses that were holding on, and you also had some real civic culture there that was kind of unique to this place. Brass bands, for example, which are sort of a tradition in that area, in addition to sort of these parade societies, you know, they come together and put a float together for the Mardi Gras parade. So there were people who knew each other. There was something to build. There were assets in this neighborhood, but by and large, it was suffering. It was a very interesting character. You'll see on each one of these three examples, there's always, I think, in my mind, there's sort of a hero. You know, there's somebody who really is the moving force behind it. In this case, it's a kid named Jeffrey Schwartz, he was a local New Orleans boy who went to MIT, got an urban planning degree, came back and really took on as his mission to try to figure out a way to revitalize this commercial corridor, and started with things like tree plantings, barbecues, concerts, other things like that to try to get the community sort of try to understand the community, listen to them, understand what they needed, but then in time try to figure out how they could find a strategy, come across a strategy that could help improve this area. And at one point he was really sort of struck by this giant abandoned supermarket as maybe an opportunity right in the middle of that corridor to create an anchor, a commercial anchor in the neighborhood. And what you see in this photo is what was the result. One of his partners was Whole Foods, who was at that time trying out a new format for their stores, one which had a smaller footprint, less expensive food, and really designed to sort of designed to be placed in urban marketplaces around the country. This was the first of this type, but there have been many more now on this model. But what you can't see in this photo are around the corner is a massive industrial-sized kitchen that's now used in a variety of ways, one of which is training local youth on how to cook and to be sous chefs and prepare food so that they can take advantage of getting jobs in the local restaurant economy that's so vibrant in New Orleans. It also has community facilities, so it's got a meeting room that can hold where they can hold meetings. It's got office space where certain local nonprofits also are able to sort of house themselves. So let's go to the next slide. So what we find is it has many components. So these are the details. It is a grocery store. The culinary medicine piece is from Tulane University. The medical school there is using the teaching kitchen to teach medical students about how you can use food and food preparation as a means as medicine. You find that there's also an opportunity. They run a small cafe out of that kitchen. They also do training, and as I said, they have the meeting space, teaching. They have a farm on the property, and they have case managers who help connect people to social services there on site. Some of the key stakeholders in this case were the broad community connections. That's basically this kid who started this nonprofit to link together the community. L&M Development Partners was a for-profit development company with experience in doing mixed-use development around the country. They also built some affordable housing in this neighborhood. The Low Income Investment Fund is a nonprofit bank, what we call a community development financial institution. Whole Foods, Tulane University, Liberty Kitchen is a social enterprise for job training. First Line Schools, Boys Town, and Sprout NOLA are all nonprofits focusing on at-risk youth. And then, of course, we have J.P. Morgan Chase and Goldman Sachs, two of the largest investment banks in the world. So I don't know, for those of you who don't have much experience with these kinds of projects, it must seem odd to see Goldman Sachs together with Boys Town, but that is really typical for community development investments. The financing, how do you pay for this? So part of it comes from the New Markets Tax Credit Program. That's about $3 to $5 billion a year from the federal government, really focused on business development in low-income zip codes. There's a group called, there's a subset of that called Healthy Food Financing Initiative, where some of that comes from. In this project, there are philanthropic funds. Newman's Own, for example, has a foundation that puts some money early on into this property. You have market rate loans. So these are, when you have the grocery store makes money and they're able to pay a mortgage. And so this is something that I think often gets lost with our health partners, is we try to remind them that those of us in finance really try to make every single dollar work as hard as possible. And by that, sometimes we use words like leverage or capital stack or some of these other technical terms. But the reality is, what we're trying to say is, you can get more out of a dollar than just spending it as cash. You can use it as, think of it as the down payment that you put on a house, and then you borrow the money against your the income you have from your job, and you can leverage those down payment dollars really substantially. That's similar to what we do in all of our projects to get much more money on the front end in order to make really big changes in the community. There are also low interest and subordinate loans. Some of those are from public sources like the City of New Orleans. So the project opened in 2014. It was about $21 million development with 60,000 square feet. And I want to go to the next slide and talk to you a little bit. What was the strategy behind this, or its approach to addressing the upstream social determinants of health? So one, we have economic stability. So the store is really, as I mentioned before, trying to anchor this community to provide jobs. 50 jobs that came from the store, and then all types of youth training and placement programs. In addition, they're trying to play a role of incubating small businesses, whether that's catering or food trucks or other sort of food-related businesses. In terms of education, you have culinary and nutrition education for medical students and public health students. You even have doctors coming in and getting continuing medical education credit by going through courses at the kitchen to sort of think about nutrition and cooking as a means of improving health. There are offices for a nonprofit charter school management organization and other youth development programs. Now, there's also a focus on specifically on health and medical care. So you have community cooking and nutrition classes, which are linked to the clinical recommendations that those patients have. You have health care access through on-site screenings and nearby community health clinics. So they become a sort of what they do is they screen and they refer, and that's really a key part of what happens at this location. This is a beautiful development. It has made a big difference in that area and is attracting more investment as a result. And so you're starting to see a lot of those closed storefronts begin to open up, and a lot more traffic along that broad street corridor, including pedestrian traffic, which was almost non-existent before. And then the social and community context, there's a lot of community buildings going on in terms of I mentioned that this project started as a tree planting and barbecue as a sort of a social capital effort to knit that community together. Well, it's really just been accelerated and accentuated through the existence of the building, and now they do all kinds of gardening classes and other sorts of efforts to engage the community. Let's go to the next example. This project is in Stamford, Connecticut. It's called the Vita Wellness District. And just this photograph, if we just focus here on this for a second, this is housing for the poorest people that live in Connecticut. I mean, there are, and what's interesting is this was formerly, this was housing that was provided to people in a sort of a concentrated way in these areas that were cut off from the city, and they were exclusively low income, and that's what the housing stock was before. This project has 7 different sites throughout the west side of Stamford, a relatively poor area in a very wealthy part of the country. And what you see here is by door, these are mixed income, so some of those are market units, some of those are low income units, but you will not know the difference from one to the other. And I guess, I wrote a book about community development years ago, and one of the quotes I got from somebody who was in one of these properties was saying, when I love living here because when I order a pizza, they're not afraid to deliver it to me here. And you may be talking about pizza is not a good idea on a health call, but it's that sense of pride, there's just really something special when you hear someone talk about that pride of location and where they live. And we know that sense of well-being and that sense of control over your sort of destiny and your future and your circumstances really equates to better health outcomes. But in essence, what this project was an effort to bring together a hospital's effort to expand together with a housing authority's effort to redevelop its housing. And it was really, in this case, the hero in my mind is Vincent Tufo. He's the one who was in charge of the housing piece of this. And he realized that he had gotten wind of the fact that the hospital needed to expand, But the hospital owned different parcels of land in the west side of Stamford, but it didn't have property adjacent to the hospital. But he did. He owned a parcel next door. And he thought, there's got to be a way we can do this together. And so he was beginning to sort of make inroads with them at the same time that the hospital was doing their community health needs assessment that Elizabeth alluded to earlier. And they identified this neighborhood as the area of the greatest health need in the area. And so at a key moment, they came together. And I just want to say that it really is, this is a quote from Vincent Tufo. We were incentivized through what was a HUD grant to think about partnering with other community service organizations like Human Services, Job Training, Economic Development, he says. We started to think about how we would help improve the self-sufficiency of public housing residents. And you can imagine, at the same time, the Stamford Hospital Director of Public Affairs, Cam Kaprowski, said this, quote, we realized that just plunking the hospital down and plunking in new housing wouldn't necessarily improve the lives of people who live in the neighborhood. We wanted to make sure this was managed in a way that would give opportunity to the people who are in the neighborhood, achieving a rebalancing of the neighborhood instead of gentrification. So that was really the sort of the driving impulse with this leadership, both from these two entities. We can go to the next slide. I'll give you some more details about the property. So this is a mixed-use development. So that means that it's got housing and some businesses located in it. It's mixed income, which means that some of the units, as I mentioned before, are rented to the very poorest people of Stamford, and others are rented to people who can live anywhere, who can pay market rate. It's got a community farm, which is really powerful. I mean, it's not just a little farm. It's large. The farm is managed entirely by volunteers, and it's vibrant, and it's always filled with people in the spring and summertime, and it really is a catalyst for bringing the community together. There are all kinds of ways in which they built, because they were building all this new housing and redesigning the hospital. They did their best to try to integrate the housing and the hospital into the community, make it more walkable, try to link it together in many ways in a more deliberate way. The key stakeholders were Charter Oak Communities. This was a spin-off of the Housing Authority, which is a public-private entity. The Stamford Hospital, the City of Stamford, Stamford Community Collaborative, residents and property owners. And I can't emphasize enough that it was really the residents who, if you don't have buy-in from the residents, none of this stuff works. You can spend a lot of money and not make a difference if you don't have that kind of buy-in. The financing was a collection of different sources. The U.S. Department of Housing and Urban Development through the HOPE 6 program, which is the modern version of that is now called Choice Neighborhoods. The low-income housing tax credit, that's a federal program that's about $14 to $15 billion a year. It's administered by the states, and I do want to pause here just for 1 minute. The states have an important role to play with this program because these are awarded on a competitive basis, and there's always more demand than there are credits. So whatever you put in the sort of what we call the qualified allocation plan, whatever you put in as sort of where you get points for a higher score, the developers will do that. And we had one of those Healthy Communities meetings in Ohio with the Cleveland Fed, and at one point the director of the Ohio Housing Authority said, Housing Finance Agency rather, said, he said, after this conversation I've really changed my mind. I always thought I was a housing guy, but now I see I'm a health guy. And he said he's going to put social determinants of health requirements into those who will get the winning bids for these tax credits. So it's a really big system that could be, at the state level, that could be targeting more upstream social determinants of health investments. There was private equity in this. There were city grants. There was quite a bit of capital in this project from the state. There were general obligation bonds, both at the city level and the state level, and the hospital also floated bonds through a state authority. the hospital also used its own equity, its own investment dollars, as well as community benefit dollars. So the project was launched in 2011. They've completed 6 of the 7 new housing communities, and this was the swap that took place. So the hospital had those 7 parcels that it gave in exchange for the one that was next to the hospital expansion, which they saw as a fair trade. But then, in addition to that, they saw the benefit of improving the people who were their likely patients, improving their health, improving their upstream social determinants of health by making this investment. It wasn't cheap. You'll see the scale is pretty large. The neighborhood that there was for just the housing section was $186 million, creating almost 400 units of housing. And the hospital expansion was about $450 million. So next slide, please. So again, what were the social determinants that were addressed? You had housing, of course. We know that people who have stable, affordable housing tend to move less. Their kids tend to stay in school. They tend to do better. They have better outcomes. It's easier for people to keep a job, get a job and keep a job. All of this tends to the house becomes something of a platform or an anchor, so that certainly improved their health. In terms of economic stability, they really took on an effort to try to link to the hospital system so that you could start targeting some of the training to the hospital and the two local federally qualified health centers. And the local community college came up with a special program just for the residents of this project to go ahead and train them in order to take health jobs in the neighborhood. You saw there were all kinds of efforts at increasing education outcomes at every level. The hospital expanded, of course, but the hospital had been making a very concerted effort to really focus on behavioral health, dental care, and work with the 2 FQHCs in the area to really focus on social determinants of health. They opened a gym and have worked pretty hard on efforts at getting access to healthy food, not only through the food that they grow themselves at the urban farm, but through other programs. Now, this was, like I said, huge production. As you can see, well over, $550 million worth of redevelopment in Stamford, and there was a real effort to try to use this opportunity to bridge some of these pockets together, to work on sidewalks, to work on lighting, to work on making it inviting to go from one neighbor to another, to get out and walk. But at the same time, there was what they call a defensible design to it. So much of the housing used to have through streets, but now have cul-de-sacs as an effort to try to minimize what was happening, which was people engaging some kind of illicit activity and then making a quick getaway. It's harder to do that now because the streets, it's impossible, in fact. So you saw a much improved public safety situation here. And then the social and community conditions, this couldn't have been possible, again, like I say, without the deep commitment of the local residents who were motivated to participate in this redevelopment. And it's remarkable how something like the urban farm really became a catalyst for bringing people together in this case. And like I said, the residents were consulted at every step of the way here. Okay, next example. Now this is my last example. The villages of Eastlake in Atlanta, Georgia. This was an example where this was a public housing project. It was known as Little Vietnam, not because people of Vietnamese ancestry lived in this area, but because it was a war zone. It was so dangerous, and it was. As Carol Naughton, who is, I think, the hero in this case, along with the resident leader, Ava Davis, they were the ones who were the leading pair behind this. And they put together a plan that included the residents as part of it, although it was very controversial because they had to close down the existing affordable housing and relocate people and then bring them back. They were so nervous about that they decided that they felt like they needed to do a vote for everybody who was in the existing housing project in order to do it. And there were entities, in the project that were benefiting from the way it was, including some people who were involved in the drug trade. And this woman, Ms. Davis, just stood up to them in a way that was really an inspiration. And they won that vote, and they did go ahead with the project. But as Carol likes to say, the only thing that was working in this place was the drug trade. They had, in the education realm, they had about 5% of their students at the local elementary school reading at grade level, or performing on state standardized exams at grade level. They had only about 13% of the population was employed at that time. And after the redevelopment, where they engage in what we now see as kind of the state-of-the-art intervention, which is really sort of bringing in mixed income. So you have market rate units, people who are not getting subsidies, but you make it nice enough that anybody would want to live there. And then you've rebuilt all of the affordable housing units that were there before so that you can bring back everybody one for one. And that was true for the Stamford example and this one as well. And again, similar to the Stamford example, there is no way to tell one unit from another. It's door by door, and there's no poor door here. There's no poor building. They're all integrated throughout the whole property. And as you can see from that photograph, it's just a beautiful place. And it's just I used to do affordable housing 150 years ago when I started my career, and my rule of thumb was, would I be proud to have my mother live there? And that, if you look at that photograph, that's certainly a place where I would be very proud to go visit my mom in that development. So post-development, what happened? Well, you got the outcomes are mind-boggling. Violent crime drops by 90%. Over 90% of the kids now reading at grade level. You have 70% of the population employed. That's higher than the national average. So you have this remarkable turnaround for this whole community. And in fact, one of the things, when they talk about what was the thing they what they have done differently, they were so successful. They said, we've driven up the property values all around this area. We should have bought more land when we started. I mean, that's a real testament to how well they were able to turn things around. This property now has a public, it has a grocery store in what was formerly a food desert. It has a charter school that's doing, it has those great education outcomes. But what's interesting is they initially started, purpose-built initially was really focused on they called them the three legs of the stool, and that was public safety and crime reduction, education through their new charter school, and creating a sort of a cradle-to-career type pipeline, and mixed income housing. Bringing in, making the community more dense, but mixing it with middle-income folks as well. And what's interesting is when you talk to Carol, who started this, who was really the project manager of this project. She said, one thing we just started to notice was that in the beginning, when we first came to Eastlake, we noticed that there was a real problem with a number of obese children at the school. And after several years of operating our own charter school, we noticed that was almost non-existent anymore. And so I asked her, I said, well, what is it that you did? What changed? And I was expecting her to talk to me about nutrition programs or school lunches or exercise programs or this or that. Her response was, we taught all of the first graders how to play the violin. And I thought, well, why? And she just said, you see these kids excited to come to school. They're doing things they never thought they'd do before. You could see that the children had these bright eyes and excited about the different experiences that they were encountering at this really enriched school that was kind of really challenging them. And it was really it really proves the point that if you have this future orientation, so many other things about your health kind of take care of themselves. Can we go to the next slide? So what are the details of the project? It's, like I say, mixed income housing. It's really focused on the charter school. It's sort of at its core. Has all kinds of recreational facilities, almost too much in some respects. They even say there was an adjacent golf course that the residents have access to, but they were saying it's a little bit expensive to run that, and they don't really see that as an essential part of their formula. But it's an opportunity, an option for the residents to go play golf there. They have a YMCA on campus in the community. Like I said, they have the grocery store, park, and then they have those golf courses. One of the key, what they call the secret sauce to this, is the Eastlake Foundation. That's the first person listed in the key stakeholders. They are a foundation that's set up just to manage the revitalization of that community. It was set up by a philanthropist, Tom Cousins, in Atlanta, that really try to knit together the different sort of resources and sectors. It's only a small amount of the overall development cost, and but what it was able to do was really knit together and weave together all of these different funding streams in order to get, and these different service providers in order to create a much more coherent intervention for the families who live there. The other players were the Atlanta Housing Authority, the YMCA, the Eastlake Residents Association, and the Atlanta Public Schools, which allowed them to go ahead and build Atlanta's first charter school there. The financing came from a HUD grant. The low-income housing tax credit, again, we're going to see you're going to start see some themes here, right? The low-income housing tax credit, the new market tax credit, revenue and general obligation bonds, private debt and equity investments, and then they had foundation, corporate, and individual grants and donations. They did a fair amount of fundraising for this project. It launched in 1995, and it's just continuing. There is no flagging of energy or support. This neighborhood continues to turn out generation after generation of well-equipped kids, many of whom are going to college, and very high graduation rates. In fact, Carol will often say their scores are as high from their elementary school as the wealthiest communities in Atlanta. So the way she puts it is, we are not closing the education gap, we have eliminated it. It's a big project, 175 acres, 542 apartments. They have early learning center in addition to a K through 12 charter school. And like I say, part of the reason why I put this in there is the purpose-built communities is a network of communities that are sprouting out all over the country. And so if you are curious about them, I encourage you to look them up online. Next slide, please. And this is my last slide. Just want to talk a little bit about, so what were the upstream social determinants that they dealt with? So one, of course, is the high quality mixed income housing that you could see how proud you would be to live in that property. You see economic stability in the neighborhood. So they have there's a sustainability in part because of revenue from some of the things that they have, like the golf course. They also have job training and trying their best to sort of put people into opportunities of economic gainful employment. That's where you can see the 70% employment figure is a testament to that. They have the cradle to career in education, the cradle to college pipeline. They're really trying to sort of mimic in many ways the work of Jeffrey Canada and Harlem Children's Zone on just sort of getting those kids really early and making sure that they have a enormously enriched childhood experience so that they arrive at kindergarten ready to learn and that they're challenged at every step of the way to do the best they possibly can. They, like I said, did not really focus on public health and medical care at first. You did have access to food through the grocery store and physical activity through the YMCA, the golf course, the parks, etc. But and trying to get residents insurance, but they are really now focusing a lot more on sort of health as an outcome. In terms of the neighborhood and physical conditions, you know, that picture speaks for itself in some respects, but just to list these off, the grocery store, an urban farm, a farmer's market. It's now a safe, walkable community, and you see all types of those parks and recreational activities, amenities. And finally, you have the social and community context. The school becomes a gathering place. Parents meet each other. There's such a sense of pride in this community that there's all kinds of community building events. They have gardening classes, youth and senior resident programming, and really all of these places trying to sort of get people to sort of invest, root in and root for their community. It's an amazing model, and like I say, it's being tried in many other places as well. Those are my 3 examples. I would like to draw your attention. I took these 3 from, I stole them really from the Build Healthy Places Network. They have these 3 examples in detail on their website, and in a program they call Community Close-Up. They have many more examples like these. These are just the 3 I picked in the time I had to talk to you. But I would encourage you to go on their website, buildhealthyplaces.org. And that's in many ways, they're a grantee of the Robert Wood Johnson Foundation, and they are working hard to try to bring together health and community development. They've been a close partner of ours in the Federal Reserve Healthy Communities work from the beginning. And thanks very much for this opportunity to talk to you all, and I'm looking forward to your questions.
Great. Thank you so much, David, and thank you too, Elizabeth, for your, those were just great presentations. I learned a lot, so informative and quite engaging. So we have had a couple of questions chatted in during the presentations, but note, if you do have a question, if you see the chat box on the left, you can put your question in there now, or I'm going to get Holly, our operator, to provide us instructions about how to unmute your phone if you'd like to ask a question that way. Holly?
All right, ladies and gentlemen, if you'd like to ask a question over your phone line, press star then 1 on your telephone keypad. To withdraw a question, press the pound key.
Okay, great. Thanks, group. I'll start with some of the questions that were chatted in, but feel free to go ahead and keep chatting them in. And let me also call your attention to the fact that there were several, the Build Healthy Communities that David just referred to, there were some links to those that were put in the chat box as we were going through for each of the 3 case studies. So first question, can David or Elizabeth recommend a couple of examples where neighborhood economic development investments intentionally from the beginning focused on not displacing low-income individuals and families? So David or Elizabeth?
So briefly, in the whatworksforamerica.org, that's Investing in What Works, it's based on the Investing in What Works book. It includes a lot of interesting case studies, including Neighborhood Centers, which is in Houston, which is in the Dallas Fed District. And it specifically was made to make, it was specifically designed to make sure that as properties increase, that people wouldn't lose the ability to remain community members of that community. David, did you want to go more in detail about examples from your book?
Well, sure, and I should say too, this is a really important issue, and I think we should, one of the ways I often talk about it is we should assume we're going to be successful, so we need to be thoughtful about how can we anticipate that the improvement will trigger gentrification and displacement pressures, and so the only strategy we know at the moment are things like land banks and other ways you can sort of grab some of the parcels out while they're inexpensive, put them in the sort of public domain so that they can be developed as affordable housing downstream. I should say that if you're interested in this topic, we just did a literature review on it. It's quite good. It's long, I'm afraid, but it's if you just Google Federal Reserve Bank of San Francisco and gentrification and displacement, I think it comes up in the first link. But it summarizes a lot of the strategies that are used to sort of try to avoid whether it's inclusionary zoning or in lieu fees for building new housing or other ways in which you can sort of generate some funding or some strategies to keep people who are residents in place so they're not displaced. I just want to add that there's also, as big of a problem as this is in places like Dallas and Houston and Boston and San Francisco and New York and Chicago and Washington, D.C., about almost 90% of census tracts are not experiencing any significant increase in rents in the last 10 to 20 years. So it is a severe problem where it exists. So I don't mean to diminish that, but it's also, there are a lot of places where building projects like this would not actually affect the market that profoundly.
Okay, great, wonderful answers. Well, Elizabeth, did you have something else you wanted to add?
Yeah, I did want to add. There are a variety of tools also, like community land trusts, limited equity housing co-ops, housing trust funds, et cetera. So there are a lot of tools, but I think what's important also to put this in the larger context is we're seeing more and more segregation, where you see the hollowing out of the middle class. And so this part of what has to be the conversation about gentrification is talking about the importance of having mixed income neighborhoods. And that doesn't necessarily mean, the uber wealthy next to the uber poor. But what it means is that there has to be a scale, a gradation or a spectrum of housing prices within a community, so that when people are moving up or down the income or asset ladder, it's not as such a hard fall if they're moving down, and if they're going up, they don't necessarily have to move out. They can still be contributing to that local community. And so it's definitely, and part of what we're also seeing is the labor market polarization. We're starting after the recession. What we've seen is, it depends state by state, but what in general we're seeing is that post-recession, when you see job growth, there's more at the upper and lower wage spectrums, but not as much job growth in the middle. So what that means is you're seeing more jobs that are paying high wages or low wages, but not in the middle. So you also see that then therefore in housing about what people can afford. So when we talk about gentrification, at the end of the day, this is really both a people and place-based issue. Are people able to work up a career ladder so that they have entry and exit points as they work up their career ladder in terms of more training and education and higher paid jobs and better jobs? At the same time, is the housing stock available where they can gradually move up, or are they stuck in either a higher income or a lower income area?
Okay, great. Thank you. We'll take another question off the chat box, and then I'll see if there's anybody that's wanting to ask a question on phone. But one of our questioners says, during the recessions and in the last few years, state and local public health has lost a lot of their workforce and, of course, their resources, and a lot is going into, of course, the implementation of the ACA. But it's leaving public health agencies with fewer resources to expand this really valuable Healthy Communities work. And do you all have any thoughts about some strategies and tools to fund this critical function for public health, or how public health can be engaged? Of course, you've mentioned several places where they've been part of the Healthy Communities project itself, particularly around healthier foods and fitness and wellness. So I'll turn that over to you. Do you have any thoughts about that? Helping fund public health activities to be engaged in Healthy Community work.
David, did you want to start, or are you?
Sure. So I think one of the things where we see some real value, I think, is or some excitement is around pay for success financing. And again, I think if you just Googled Federal Reserve and pay for success, you'll get a collection of essays on that gives you a background on it. But that, in essence, are things like the social impact bond or other tools where you're finding a way to identify a downstream cost that is avoidable with some kind of an upstream investment. So some of the ways this is played out across the country, there's about 50 examples of this across the country at this point. Only 2 have been completed, but about 40 or 50 more in the works. But if you have a downstream cost like incarceration costs, emergency department costs, special education costs that are avoidable if you go upstream and provide, in the case of special education, for example, an enriched childhood experience like the social impact bond in Salt Lake, Utah, or if you can find a way to do better case management to keep kids out of prison, like in the Rikers Island in New York City social impact bond. There are examples where I think public health can play a really key role in using its facility with data and analysis to sort of target some of those areas and be part of the teams that put them together. So in South Carolina, it's the Nurse Family Partnership is working across the state to do some type of finding a way to pay for its home visits as a way to improve social outcomes in South Carolina. But I think that I think public health has a real role to play here, not only identify where the needs are, but maybe even measuring whether or not there's been progress. And to some degree, it's an uncomfortable thing to say, but to even monetize some of the savings that come out of those interventions. The second area that I see a lot of excitement around is just this shift we see in the medical care world from volume to value, and this idea that rather than getting paid per procedure, you're getting paid per year to keep somebody healthy. And I just feel like there's got to be a way that public health can kind of tap into that in some way, in part because you know these communities better than anybody, and you could be the guides that help people make the right strategic investments. We had this very strange experience where we had a meeting at the New York Fed, and the head of the Medicaid program for New York said, look, I have a waiver now. I'm going to spend $100 million on supportive housing for high users of the medical care system, but I don't know who to partner with. I don't know who's out there that does that kind of housing. And we know those people and we can connect them, but the public health people might know them too, and you could play some kind of a broker role perhaps to kind of make those connections.
I'd also like to add that it takes a village, right? So this is about collective impact. So we're talking about within the public health, healthcare, community, and economic development world, we have the shared vision of solving a specific problem. The specific problem is we are not doing better in terms of health. We have higher infant mortality rates in our country than many other industrialized countries. And so if we're talking about making healthy the norm, that's the shared vision. So if we can come to a common vision and shared vision, and then we say, okay, how do we measure what we want to accomplish? What are the short and long-term outcomes that we're looking for, and what's the long-term, what are the outcomes, the impact that we want as well? Then the essential critical role that public health can play is talking about use the epidemiological and biostatistics data to say this is what we're seeing in terms of trends, in terms of patterns. These are the highest priority areas that we need to reach. And so it's not just about where's public health money going to specific public health projects per se. It's part of a much broader conversation of saying we are all in this together. We know where the biggest areas of concern are. Our area of expertise and our value add is saying that we know what the trends and patterns are and what the most severe health issues are, and you need to include these health indicators along the way to know what your short and long-term outcomes are and should be, as well as your impact. So the public health voice and expertise is an integral part of this conversation of how do we create a culture of health, and even if it's not a project or program per se, what's valuable is saying this is the data that shows what's working and what's not, so we know where to direct funds into something that will create a success or to create a successful outcome.
Okay, great. Thank you. We've got several more questions that were chatted in, but I wanted to pause and see if anybody on the line wanted to ask a question.
We have no questions on the phone at this time.
Great, thank you. Okay, so what are some strategies that these projects have used to keep key stakeholders engaged?
Let me give an example of what's going on in Dallas. The Children's Medical Center changed its name to Children's Health. So now it's known as Children's Health. And they launched the Health and Wellness Alliance for Children, which is a collaboration between dozens and dozens of entities from the public, private, and nonprofit sectors. And the main goal is addressing childhood obesity and childhood asthma. And then they have working groups to address specific parts of of asthma and of obesity. And one of the things they found in terms of asthma is that there were high trigger rates of asthma attacks in a certain zip code, and they found out because part of it is, initially the response was, well, let's just make sure that the kids are taking their medication as needed. But when they dug deeper, what they saw is the housing conditions in general were poor enough to trigger some of these problems. And so especially when they're during allergy season, it was made worse, but it was already an environment that was not exactly ideal or optimal for someone who has asthma. So they're actually, the Health and Wellness Alliance, to all these multiple partners, are working to change, to increase funding, and the City Council has actually, I believe it's passed it already. If it's not, it's in the process of doing so, to increase code enforcement of housing code violations. So you see this mix of different sectors working together to have a common goal of reducing childhood asthma, but when you dig in deeper, we're seeing that the areas that we're seeing the greatest, for example, preventable asthma attacks, are in places that have poor quality and unsafe housing. And if code enforcers had the education and because some code enforcers, of course, know what they're doing, but some maybe need to have more training to do the best job possible. And I'm not saying that they're not qualified, but what I'm saying is that there may be some triggers that they may not be aware of because they're not trained in health, or health care. So if they can do a better job at ramping up, if the city can do a better job at ramping up its code enforcement of housing code violations, then how can actually help reduce the preventable asthma attacks. So that's just one example of a multi-stakeholder engagement that takes a social determinants of health approach and a collective impact, using a collective impact model. That's in the backbone organization there is Children's Health.
I'd say too, that's a great example, Elizabeth. And the three that I gave, I think are good examples too of people staying engaged. And there's Neighborhood Centers Inc. in Houston that I think is another great example of this, where you've got it, and they all have these common elements to them, right? They're cross-sector, so that means they're bridging health together with education, transportation, community development, et cetera, to sort of really do a holistic redevelopment of the neighborhood and really helping those neighborhoods become places that promote health rather than detract from it. So they're cross-sector, they're place-based. It's really hard to do things differently than you've done in the past. As much as I want to talk about cross-sector work, at the end of the day, my boss counts how many publications I put out and how many speeches I give, and if I don't hit my outputs, I get reprimanded at the end of the year. So even in my own job, it's hard for me to sort of get outside of my silo. But if we really care about a community, whether it's New Orleans or it's Eastlake or it's these places where there's a passion about this place, that helps a great deal. The daring work of Eva Davis in Eastlake is an example of that, where she just passionately cared. She raised her children there. She saw her grandchildren being raised there. She wanted it to be a safe place for them. And so you have to be place-based. You have to be data-driven. You have to have trust from the community. If the community doesn't believe you have their best interest in mind, you might as well not even start, because that's the key. And then there's got to be some type of this backbone organization, as Elizabeth said, somebody who's kind of really playing the role of knitting together all of those different sectors, and somebody who's kind of held responsible at the end of the day. We in the What Works book, we refer to that as the community quarterback, which I know is a not ideal term, but I like it better than backbone organization. But one of the things we found in the What Works book is, and some of these other examples, and you saw it a little bit with how I told those stories, with whether it's Jeffrey in New Orleans or Carol in Atlanta or Vincent in Stamford, it's there's almost in every case there's a charismatic super genius behind these who typically has a close friend who's a billionaire. So we know that's trouble. I mean, we know that's not replicable. But to back to this question, how do you keep people engaged? Oftentimes it's these really remarkable people who can somehow just through the sheer force of will do this. And I think it's been important that they did it to prove that it can be done. Now the challenge is how can we just train people to do it, just regular people to do it, you know? And one example of this is Citibank has a foundation, and they sponsored a community quarterback grant program they call Partners in Progress. And they had 14 grantees, and these were not extraordinary people. I mean, they were smart, and they won the grant. But they went through 2 years of sort of training, and they had some extra funds from the City Foundation to support their core operations. But when I talked to that group by the end of 2 years, I told them often, I'd say, look, if you're in a negotiation with the mayor and the head of the local foundation and the head of the local bank and all these people that seem like big shots, don't be intimidated because you're the most important person at that table because all the rest of them can be replaced. You can't. And what I found is that when I visited them 2 years later, the stories that they had were remarkable, where they were able to get massive investments from hospital systems, from the education system, from other organizations who basically began to trust them to say, you're getting results and we are desperate for that. So I think at some point, there is a ramping up of demand for social change, and some of this is driven by just the need to improve health outcomes, and some of it's driven by other forces, but increasingly you're going to see a demand for this type of activity, and I think you'll see the leaders come to the fore and become those catalysts, and they don't have to be super geniuses with deep pockets. I think that's a trend that's underway, and I think we'll see more of it.
I think you're right. I agree with you. Let's move on. We had a couple of folks ask questions about calling attention to the fact that the examples you mentioned were in urban areas. Are there examples of work in rural America, or how do we specifically address healthy communities in rural areas?
So for example, for banks under the CRA obligations, they need to invest in their assessment, in community development in their assessment areas. So banks that are in rural areas, you can approach them and say, I want to see your CRA public file. And through that, you can see what are their priorities in their rural market. And from there, engage in a conversation and say, I understand that this is your perspective and your priorities. Let's talk about potential ways that we could collaborate. That doesn't necessarily mean the bank will say yes, but if you come saying, we've read what your priorities are and this is what we think we can do to help, at least you're engaging in the conversation, and that's the most important first step to take.
And this is a great question, and we are terrible at rural development in this case. And I've often thought that it should be easier there because when you want to do a kind of a cross-sector collective impact type intervention, you should be able to get everybody around a table because they can actually sit around a table, But one of the things that I was really intrigued by, places I think to keep an eye on, one was this meeting in Montana, which Montana is an interesting place. It's a massive state. I mean, it's just geographically speaking. But there's only 1 million people who live there. And the way they describe it, it's a small town with long streets. And I think you're starting to see a real sort of knitting together of different leaders from different sectors who are really focused on this issue of improving the upstream social determinants of health. And I think places like that you might see a breakthrough. Another place where I think you might see a breakthrough in rural on this rural question is I'm bullish on Hawaii because I think what's interesting about Hawaii is there are only 2 health insurance companies, and they each have about half the population. And all the islands, other than as soon as you get out of Honolulu, the whole place is rural. And Kauai maybe has 60,000, 70,000 residents. And what's cool about Hawaii is that each island is also a county, so all the health data are collected at the appropriate level. And there's a really interesting opportunity to do sort of pre and post intervention analysis because it's going to be, the data are collected automatically. And I think you also have some native foundations that are holding tremendous resources to benefit the native population that haven't been deployed as well as they might have been, I think. I mean, there's ways in which I think we could activate that as a resource in addition to some of the other federal programs that had been mentioned in these three examples. And so I think there's some places where we can kind of hotspot sort of breakthroughs in rural activity, and I'm looking to Montana and Hawaii as places where that might happen.
Great. Okay. We've got a couple of more questions in a few more minutes, so these are a little bit more technical. But the first one is, does your local Federal Reserve branch need to prioritize healthy community development work in order to collaborate with them?
No, healthy communities is community economic development and vice versa, but they may not call it healthy communities. So depending on where I am geographically speaking, I've noticed that the response to when I say healthy communities, sometimes people totally get it and embrace it, and other times they get it, don't embrace it, and other times they don't know what I'm talking about. So what I would say is, don't assume that healthy communities is the right phrase to engage potential partners. If you ask them, if you learn about their community and economic development or healthy communities or community health or public health priorities, and then use the language that they're using, but with the same goals of promoting and protecting the health of all communities, especially those most vulnerable, then you'll be much more likely to make some progress in those conversations.
And if the area were Colorado, would that be one that you had any knowledge of, kind of what the language might be there? Or
well, I'll give a shout out to one of my colleagues there. So Colorado, the Denver branch, so the Kansas City Fed has the Denver branch. So the headquarters are in Kansas City, but one of the offices is in Denver. And Ariel Cisneros is our colleague at the Denver branch, and he is, yes, very receptive to healthy communities. So if you contacted Ariel, he's very much involved in this space. Okay,
great. That's great. The last question that we have here is about Dallas. Dallas, this is the questioner has. Dallas has the second largest food desert in Texas, second only to Houston. They'd like to create a healthy corner store network and have been talking with the city of Dallas and looking at community block grants, but they're looking for other funding sources. Do you have any recommendations outside of those two?
That's a conversation I think that can go offline. We have a North Texas Funders Coalition that looks at different investment options, investment opportunities. So that's one. I think it's about looking at the community foundations as well as the, like for example, it could be banks, foundations. It could be a variety of foundations, bankers, et cetera, that are operating in this space. Also, I just heard from the U.S. Environmental Protection Agency how Dallas just won a grant from the EPA specifically to address food deserts. So I would call the city of Dallas and ask about the EPA grant that they just won. They literally just won it, I think within the last week, to address food deserts as well.
That's great.
You might
go ahead.
Sorry to interrupt. You might just Google also that Healthy Food Financing Initiative. That's a program through the CDFI fund that might be helpful.
Okay, great. And Holly, do we have any questions online? I mean, on the phone line.
We do have a question from the line of Denise Koo.
Okay, great.
And it's not really a question. I just wanted to say, I'm from the CDC. I just wanted to say to our two speakers that just loved what you all have to say, and it's so fascinating to hear you using all of the lines and the messages that we have been trying to use with the healthcare system, and you're both so incredibly articulate, so I'm really glad that we're going to have your slides. And just to let you know that Dr. Karen DeSalvo, the Acting Assistant Secretary for Health, would be totally interested. I may even take the slides and send them to her because she is very interested in saying the same message about Public Health 3.0, Time for an Upgrade, which is an editorial that we just published in AJPH. Wonderful, wonderful stuff. I'm really glad to hear you saying it. And I wanted to let the rest of the audience know that APHA will be announcing a Healthy Cities and Counties challenge on the first day of National Public Health Week that is, again, totally aligned with this idea of multi-sectoral approaches, and will offer some prizes to small to medium cities and counties that are taking this kind of multi-sectoral approach. So be on the lookout for that announcement April 4th.
Great. Thank you so much, Denise. I'd like to end the Q&A session now at this point. If you have follow-up questions, please use the contact information that you see on the screen here, and we'll ensure that our speakers get your questions. Let me go ahead, since we just heard from Denise, and thank CDC for sponsoring this call. And let's just give a virtual shout out and round of applause to our speakers, Elizabeth Sobel-Blum and David Erickson. That was just a fascinating dialogue and presentation, and I think you could tell from the kinds of questions you were getting that people are so interested in this. So thank you guys so much.
Thank you.
Yeah, great. Thank you again, audience, for joining us today. More information on this call series is going to be posted on the ASTHO website that you see on your screen. Future calls will cover community health needs assessment and state innovation model plans, behavioral health integration, and community development. This link also has archived recordings and resources from the payment and delivery reform TA call series that we had last year. So you can see there's a link for our webinar evaluation. You'll be getting that. You'll be directed there. We appreciate your feedback. We use it to plan future calls. Recording of this call, several of you had asked about that as we were going through, and also about the slides. They'll be available on our website in the next few days. We hope this webinar is useful as a resource, and please feel free to share this link with others who might find it useful as well. Information on the next call will be available soon, so please contact Kristen Rigo at ASTHO with any questions. And with that, we want to just thank you for being with us, and enjoy the rest of your day.
Once again, we'd like to thank you for your participation on today's conference call. You may now disconnect. Speakers, hold the line.